Hello, my name is Eliana Robinson, and I'm a student at the Indiana State University's Doctorate of Athletic Training program. This video is just a short video to discuss my reflection of how I go through an ankle evaluation and do decision making on ankle injuries. So to begin, I'm going to talk about how I currently evaluate an ankle and the specific steps that I would go through. So the first thing that I would do is that I would assess the patient as they walk towards me, or as they come towards me in whatever way they can, or as they walk into a room. I'm pretty much looking for any gait abnormalities, tapings, wraps, or braces that they could be wearing. The second thing that I would do is let the patient actually start talking to me first. So they may introduce their problem or injury, which sometimes will give me the mechanism of injury as well. And sometimes, being at a high school, the patients don't actually introduce themselves, and therefore I go to the next step, and I usually ask the patient basic information such as their name, birth date, injury date, grade, and sport. And then with that, sometimes I will start engaging in a normal conversation with the patient, and it may or may not be about their injury. It may just be about a connection that we might have, or about their a conversation based off of their basic information, something of that sort. So, and those conversations can be in different lengths depending on how well I know the patient and how close I am to them. The next step would be to ask subjective questions. So this will start the subjective portion of the assessment. This is where questions about the specific mechanism of injury will come into play. Also include patient history, which will not only include just general medical history, but more specifically geared towards any histories of injuries within that area that they are complaining of. I would also ask about family history, especially with chronic ankle injuries. Could have been inherited, say weak ankles from their mom or dad or someone in their family. They all have a similar, the family has a similar issue, so that's always good to know. Also ask about the typical pain levels, visual analog scale specifically. Also looking at the type of pain, referred pain, any compensations that they have made for their injury that could also lead to referred pain, or not really referred pain, but pain maybe in other areas of their body. Also looking for neurological symptoms and home treatments. So then, after asking a lot of subjective questions, I'll usually assess visually. So I will, hopefully, if I've noticed any antalgic gait issues, braces, tapings, or wraps worn, I will have made a note of that. And then I'm also looking for bruising, swelling, redness, and obvious deformities that could indicate what the injury could be. Then I'll go directly into palpation, and I typically do my palpations from distal to proximal of the injured area, instead of starting directly on the injured area. I usually try to play it safe and go further away from the injury first. That way I do not cause immediate irritation. And then I will also hopefully be ruling out a fracture at this point with palpation and visual assessment. Then I'll perform range of motion in the specific order that you see, and then the resistive range of motion will lead into a manual muscle testing of the surrounding muscle or muscles of the joint and the foot, of the joints of the ankle and the foot. And then soft tissue testing will come next. These will be picked based off of what findings or differential diagnosis I have been able to come up with at this point. So at the bottom it notes that steps 5 through 8 use bilateral comparison. I go As I do it, I usually try to do the testing on the uninjured side first, and then go to the injured side. And then as I go through this process, I write down everything that I find necessary to write down, especially any positive findings, but as well as just general assessments or notes that would be good to remember about the patient and the injury. Then I have an assessment hopefully made, or at least a differential diagnosis if a specific assessment isn't able to be made at that point. I'll educate the patient on the assessment by discussing what I'm talking about in the first place. So if I give them a specific injury that I believe they have, such as a lateral ankle sprain over the ATF and CF, then I will explain what that means, what those ligaments are. And then after I've explained kind of the injury and how it, give them an idea of how it happened, then I'll also ask the patient about any goals of theirs, specifically if they're an athlete and how they want to, or if they want to return to sport, and ask about timelines as well. Then I explain actions that are needing to be taken, as in immediate treatments within the next 24 hours. I usually try not to do more than 24 hours because it usually is hard for the patients to remember more than just those basic details. And then depending on how the situation pans out and what the injury may be, I will call the parents and guardians to explain the situation and discuss treatment and referral options. I know I only have referral down, but I also discuss the treatments. If it's a younger patient, like an elementary or middle school student or athlete, then I always call the parents, just because I know it's overwhelming for them to hear all the information and remember it. So then after explaining everything, I usually try to apply any necessary treatment that I can personally do. And then I'll explain to the patient how to do it themselves if it is applicable to them. And then if the parents are also still around, or the guardians, I'll ask all of them if they have any questions or thoughts at the end, and then make a follow-up appointments, and then also explain what the follow-up appointment will be about. So I made these 5 basic goals after reflecting on the way the current evaluation process is and how I go through it. I've realized that there are some things that I believe I'm really strong at doing, such as educating the patient at the end about their injury and about treatment. I consider myself very good at having a good discussion with parents, guardians, and even teachers or coaches about the situation at hand, and giving them time to reflect. But these 5 goals are things I can work on. So I don't really do a lot of goniometry, although I did say that I measure range of motion. Usually end up eyeballing it because I didn't have a goniometer for a while. So I definitely could incorporate more specific measurements that would really benefit follow-up appointments, especially the ones that are for rehab. And then I'll also need to incorporate more parent opinions and goals, because I know I ask the patient about them, about the goals a lot, or, I ask them if they have any questions or opinions, but I don't necessarily always include anyone outside of the evaluation process about their goals. So parents and guardians, I don't really incorporate them in the decision-making process. I just give them my decision and ask if they are okay with it. So, engaging more in that kind of discussion with them. I also realized as I went through this evaluation process that I don't always ask about medications, so that's something that I need to work on. Also engaging in more conversation with the patient during the evaluation process and not just at the beginning or the end. And then lastly, tell the patient about my own goals and why I chose them. Sometimes I'll just go ahead and ask them their goals, and then off of that, with my own personal decision making process, I tell them what we're gonna do, but then I don't always tell them why I chose that treatment and if that correlates with my own goals. So those are 5 ways that I can improve my evaluation process, and I hope you enjoyed this video. Thank you.